The problem I've noticed is that people, clinicians and patients alike, want to attribute diagnostic properties to tests that have no business naming or identifying a diagnosis. In orthopedics, the three main domains that I'm testing in the office are range of motion, strength, and nerve tension. And I talk about muscle strength testing a lot because I really want people to realize you're testing a lot of things when you do a muscle strength test. We can call this a biceps test, but more specifically, we could call it a resisted elbow flexion test, and we could be even more technical and talk about at what elbow or at what angle the elbow was bent, what load, etc. But if we do a biceps test, if we resist elbow flexion and it's weak and or painful, it doesn't tell us why. It's not diagnostic in and of itself. It could be a biceps lesion for sure. It could be an elbow problem, like an elbow joint derangement or bony fragment after a fracture in the elbow joint. It could be a nerve lesion somewhere in the upper arm. It could be a problem in the neck or even sometimes in the thoracic spine. And there are various types of disorders in the spine that we could even narrow it down to. Not only muscle strength testing, but joint range of motion testing. Again, if I want to test maximal elbow joint flexion and it's painful and or limited, it's not diagnostic as to why. It doesn't tell me why. Same with nerve tension. It can tell us that there's tension on the nerve and it's not able to go as far as its normal length, but it doesn't tell us why. We have to take each of those individual tests in conjunction with the 5, 10, 15 other simple quick tests that are not diagnostic that we do in the physical exam, and in conjunction with all the data we've gathered from the verbal history. All put together, we arrive at a conclusion about what the problem may be or what the problem is. There are absolutely tests that have more diagnostic validity. For example, ruling in or out of fracture, we want to take an x-ray. That's going to give us a very usually conclusive evidence as to whether or not the diagnosis is a bone fracture. But in other fields of medicine, we do this kind of dance as well. People measure their blood pressure and it's high, and they say they have blood pressure or have high blood pressure. And it might be splitting hairs, but I don't know if framing it that way is correct. Yes, you have high blood pressure, but it's not a diagnosis. What is causing the blood pressure to be elevated is the question. That was just a metric we took. We don't know if stress is a factor. We don't know if lack of exercise is a factor. We don't know if dietary choices are a factor. It's the same thing with going back to the orthopedic examples. Oh, I have painful biceps testing, or I have weak elbow flexion. Okay, but that's not a diagnosis. We have to use that information, like I said, with all the other pieces of the puzzle. So don't attribute diagnostic ability to tests that are not diagnostic in nature. If you're only testing one or two things in a physical exam, you're probably missing a lot of pieces of the puzzle that, when put in conjunction, will arrive at a more competent idea of an understanding of the problem. Yes, in orthopedics, there are going to be the people who had an acute trauma and it's clear with one test that the ligament is not stable and that's where the pain is. But of course, if you just did that ligament test without talking to the patient and the pain was away from the ligament, that wouldn't corroborate that that's the diagnosis. But yes, there are diagnostic tests we can use in the clinic, but for all these other tests that are giving us the fuller picture, please don't necessarily think that one or two or three or any of these individual tests are giving you the whole story.